Okay, I'm just gonna fly through the first few slides. Again, this is just review. You've already have seen this in the previous presentation, so again, I'm just gonna jump into the more pertinent information for this section. I did add one thing here on this particular slide that isn't in your slide, is this area called the pars interarticularis. So go ahead and draw your lines in this particular area. The pars interarticularis is part of the lamina. Okay, it's part of the lamina. And just like the terminology says, it's interarticularis, so it's between the superior and inferior articulating processes. So it's in between the inferior and superior articulating processes. And it's an important part of the lamina because it is an area where there are numerous amounts of surgeries that are conducted in that particular area. Also, there are some pathology concerned with that area. Okay, everybody got it? So the pars interarticularis is again found between the superior and inferior articulating processes. A very important part. A lot of surgeries are done in that area as well as pathologies of concern. For example, spondylolisthesis. I talked about this 2 presentations ago. And spondylolisthesis is a forward slipping of the vertebra due to the development defect of the pars, okay, because the pars is not properly developed. If there's some type of anomaly that's occurring in that particular area, it causes the bodies to slip, and it usually occurs in the lower L4, L5 region. L4, L5, and sometimes S1 is where this pathology or condition usually occurs. Okay, in this particular picture that we have up here, this first one here is pointing to this area over here where when you're looking at the vertebrae in the lateral view is where the notches are found. Okay, you have your inferior and superior notches, and when the vertebrae are stacked on top of another, my Siri thinks I'm talking to it. That was weird. Okay, so so when you put it laterally, it's pointing to the intervertebral foramina. Okay, so to visualize the intervertebral foramina, what projection or position is going to be best? True lateral. Okay, and then when you look over here, this angle here is in line with the superior and inferior articulating processes that are known as the zygapophyseal joints. So, in which position would best demonstrate the zygapophyseal joints? It's going to be the oblique, okay? A 45-degree obliquity, and we'll talk about that later on. Okay, 45-degree obliquity. In the posterior oblique, you are looking at the zygapophyseal joints that are closest to the image receptor. So you just learned with the thoracic spine that when we're looking at the zygapophyseal joints, it's on a posterior oblique, it's the side up. Here it's going to be the side down for a posterior oblique. It's just the opposite. let's keep on going. I believe we've already introduced to you guys the Scotty dog. Okay, the Scotty dog is what helps us to analyze whether or not we've got a good position in our oblique L spines. So the Scotty dog, when you're looking at it this way, the different parts of the dog references the different parts of the lumbar anatomy. So the ear references the superior articulating process. Then you have the leg, which is the inferior articulating process. And then here we go again. We have the pars interarticularis, which is the neck of the Scotty dog. The eye is the pedicle, and the nose is the transverse process. Now, when evaluating for an oblique L spine, we look at those Scotty dogs to make sure that they're properly aligned. But when you also look at the Scotty dogs, the nose of the dog points to the side of obliquity. So the nose is pointing towards the right side. So it's one of either two positions. It's either going to be an RPO or, what's the other one? An LAO. Okay, it's either going to be an RPO or an LAO. You'll also notice here that in this obliquity, it's pointing to the right side. You'll notice that the wing, or the ala of the pelvis, is flat. Okay? So this is also a good indicator that tells you which way the patient is oblique. So you got two clues there. You've got the nose pointing to the side of obliquity, as well as the flatness of the wing of the pelvis. Any questions? These aren't my slides. Actually, they're Mrs. Smith's slides, but I added my own stuff to it. But this is hers. Had nothing to do with that. Okay, sacrum. The sacrum is basically 5 bones that are fused to one. Remember when you're an infant, the skull, parts of the spine, your sacrum, your coccyx, they're in segments. So the sacrum itself is 5 bones that are fused into one. On the very top of the sacrum, there is a superior articulating process, and that articulates with the inferior articulating process of L5, forming the L5-S1 joint. The L5-S1 joints. How many of you guys have done a lumbar spine already? Okay. So you do your little coned down size AP or a lateral spot film is what they call it. Okay, of L5-S1. Okay. Why is it that they center right on top of L5-S1 instead of just taking the whole L spine? Why is it that we're focused on that one spot?
See more detail?
Think of the divergent beam. Because the L5-S1 is down at one side of the beam, the joint space is going to be closed. So when you put it right in the middle of your central ray, you'll see that opening, that's joint space between L5 and S1. Does that make sense? Okay. The promontory is the anterior ridge of the body of the first segment of the sacrum, and it forms the posterior wall of the inlet of the true pelvis. So it's kind of hard to see it in this view right here, but again, it's talking about the anterior ridge. So if we look at this next image right here, this is the sacral promontory. Okay, so it's the ridge of the first segment. Let me go back here for this real quick. Then you have the foramina. You have 2 sets of 4 on each side. So you have 4 here, 4 on that side, for a total of 8. But there are also 8 more on the anterior. We're just looking at the posterior. There are 8 more on the anterior part of the sacrum. Okay, so the foramina is just like your intervertebral foramina of the C-spine, T-spine, and L-spine, where it allows passage of your nerves and some blood vessels. At the very distal part of the sacrum is the apex of the sacrum. And what do you think is going to happen over here? This is where we'll find the articulation with what?
Coccyx.
With the coccyx. Okay. All right. So let's look at the lateral view of the sacrum. So as we said, it does also have articulating process at the very top that forms the L5-S1 joint. On the very sides is the surface on either side. And what does that form? The surfaces of the sacrum.
Side joints? Wait.
Okay, this is where you're going to get your SI joints. Okay, so the auricular surface of the sacrum forms the SI joint. The crest on the posterior of the sacrum, the medium sacral crest, is analogous with the spinous process of the rest of the vertebrae. So this is the spinous process fused. They're fused spinous processes of the sacrum. You have your horn, which is the very distal part. It is a tubercle that projects outward, posteriorly and downward. And then you also have the horn or cornu also of the coccyx, except this time it projects upwards. Well, we'll talk about that in the coccyx later on. Okay, any questions?
Could you repeat, please, horn where it projects?
It projects posteriorly and downward.
Thank you.
It's basically a tubercle of the inferior articulating process. The inferior articulating process of the sacrum.
And what did you just?
It projects from that.
And what did you then after that said projects upward?
This is the cornu of the coccyx.
Oh.
So it also has one, but it projects upwards. So when you straighten out the tailbone, this little horn right here, it actually fits right inside that little crevice. Fits right in there, right underneath the horn of the sacrum. So the horn of the coccyx fits right in there. Okay. Sacral canal. So the sacral canal is the extension of the vertebral canal, or the spinal canal. Right. Nothing else to talk about here. Let's keep on going. Okay, the coccyx. These are 3 to 5 segments that are fused into one. It also has a transverse process. The base is at the top, the apex is in the bottom. Not much to say about it. Small bone. Very tiny bone. Do you guys remember these? How many of you guys still mail stuff by snail mail? Do you? Some of you guys still do? Okay.
I remember when it was 32
That's why you want to use the mouse.
cents. I remember when it was 32 cents.
Yeah, what is it now?
I think it's 44 or 46.
Wow. That's expensive. Okay. That's that. Okay, so here we have a lateral, actually this picture that we have here, it's saying it's a lateral sacrum and coccyx. It's demonstrating a sacrum and a coccyx, but this is actually a lateral of the coccyx. We're missing the top part of the sacrum. So we'll talk about that later on. All right. The different parts of the lumbar vertebrae. So here we have the body, pedicles, transverse process, lamina, spinous process. This is where the area that you're going to find your superior and inferior articulating surfaces that are superimposed. It also has notches on the bottom and on the top, and when you stack them together, it forms the intervertebral foramina. Y talks about the pars inticularis. Again, the pars is part of the lamina. What else? You guys know all the parts already, I think.
We thought so too before the quiz.
Speak for yourself.
I thought so too before the quiz.
All right, you guys can review this on your own. You guys can review this on your own. Okay. What I do want to say here, though, before I do move forward, is when you are taking an L spine, remember you got to take pictures of adjacent structures. If I can't see T12, how do I know if that's L1? Okay, T12 has a rib projecting from it, right? So if that's T12, then this must be L1. But let's just say this is cut off. What's our next baseline? Now we're going to
Sacrum.
make our way from down here. So we're going to look at the sacrum. Exactly. So we can go from the sacrum, we can go L1, 2, 3, L5, 3, 2, 1. L5, 4, 3, 2, 1.
No extra credits for doctor.
You guys know I'm dyslexic, right?
Excuses. Okay.
I know. It's an excuse. And also what you want to do is you want to open up your collimator wide enough to include your SI joints for an AP. Okay? So include adjacent structures. You want to get T12, you want to get your sacrum as well as your SI joints. Okay? All right. So going back to the zygapophyseal joints, 45-degree obliquity will demonstrate those joints. If we are doing a posterior oblique, we are looking at the side closest to the image receptor. While the anterior oblique, you are looking at the joint furthest away from the image receptor. But again, it's approximately 45-degree obliquity. And you can see here in the demonstration of the x-ray, you can see that the feet, or the foot, of the Scotty dog fits nicely behind the ears of the Scotty dog. Feet, ears, feet, ears. Okay, there's the feet, and this is actually a projection from S1. Okay. So again, we can go, let's try this again. 5, 4, 3, 2, and then 1, and this would be T12 right there.
Yay.
Yay. Lateral lumbar best demonstrates the intervertebral spaces, but we're also looking at the, what are these?
Intervertebral foramina.
The intervertebral foramina. Okay, again, we want to try to get T12 on there as well as the sacrum when we're doing the lateral. Okay, let's keep on going. So be familiar with this chart. It is a useful chart. So lumbar and thoracic spine are very similar in what it is that we are trying to visualize in those positions. But again, where they differ is on the thoracic, we're looking at the zygapophyseal joints on the upside on a posterior oblique, while we're looking on the downside, any posterior oblique for the lumbar. Okay? So again, refer to this. This is a really good chart. I almost posted my face on there. I was so tempted to do that. All right. Review your landmarks. Again, this is all review. You guys should know this by now.
Sure.
Sure. All right. Position considerations for the L spine. Gonadal shielding? Yes or no? It depends, right?
Well, he has some.
Well, he has some, but what about she? Can she have one?
She doesn't need one.
Okay. Can she have one?
No,
If you're doing an L spine, why not?
unless she's a he.
Exactly, because the ovaries are right in the middle of the abdomen. So we shield the guys. We can't necessarily shield the women. Sorry, women. Okay.
It was expected.
PA versus AP. This has to do with gonadal exposure, but it also has reference to opening up the intervertebral disc spaces, and we'll talk about that later on. With PA, this way the intervertebral spaces are a little bit more open than if they were in AP, because this straightens out the back. So if we were going to do AP, what can we do to straighten out the back to open up those joint spaces? Knees up. Yeah, they bend their legs. So when they bend their legs, this is gonna straighten out the lordotic curvature on the back, opening up the spaces. Medium KV. What's medium KV? Like 75 to 85? Okay, what are you guys shooting out there?
74 to 86.
74, 70-ish? Okay. All right. Why can't we do 110? It's the abdomen.
Because we're interested in bones.
Okay, we're interested in bone. So why the
Contrast.
lower medium KV?
Right?
Higher contrast. Okay, good. You guys got it. You guys are thinking. Good. Okay, SID 40 inches, approximately. So this shows what happens when the patient is positioned in a supine position, AP projection. You have that kyphotic curve, and if you bend the knees, it will straighten out the back, opening up the joint space, the intervertebral joint spaces. So be mindful, especially if they're elderly, they can't hold that position for very long. More considerations in the lateral. Remember how we talked about the thoracic spine, putting a bolster underneath their hips to keep this back straight, okay? What we're also looking at here in a lateral position is this imaginary line from iliac to iliac is perpendicular with the image receptor too. So you want a straight back, but you also you want to make sure that there is no tilt to the pelvis, because a tilt in the pelvis will cause the area of the lower lumbar spine to close up, and it's hard to see that joint space. So put them up on a bolster if possible. Also, when you can, use a lead mat or a lead strip. Again, you guys told me last week that your hospitals don't have that. It actually will help absorb some scatter radiation, but if you guys don't have it, there's nothing we can do about it. Okay. So let's go ahead and talk about the routine views. You have AP, you have your two obliques, you have your lateral, and then your spot film, which is your L5S1. In your facilities, do you guys have a full lumbar series versus a limited lumbar series? Yes, right? Okay, so the full series are these 5 projections. So AP, lateral, bilateral obliques, and L5S1. A limited, what are we eliminating with a limited?
Obliques.
The obliques. So the obliques are limited in a limited L spine. Okay. AP. APL spine. You're going to lay on their back, legs bent. If you can shield them, again, shield them when possible. There are 2 different central rays. It's based on the size of your field light. If your field light is open to approximately 14 by 17, you're going to center at the level of the iliac crest in the mid-sagittal plane. But if your imaging field is smaller, 11 by 14, you're going to center 1.5 inches above the crest at the level of L3. Now let me ask you this. What are you guys doing out there? Are you doing the first one or the second one?
Second.
The second one. You do the second one, so a small field. Okay, how about you guys over there? You guys using a larger field or a smaller field?
Depends what tech you're with.
It depends on your tech with it. Okay. All right. So, test purposes, be familiar with both centering. Okay, one for larger field size and one for a smaller field size. Do you guys see any similarities with this? We did the T-spine, which was like a chest X-ray, but it was collimated, right? What is this? It's a KUB. It's an abdomen that's collimated. Unless you're doing the smaller field size. Okay. When is the X-ray taken? What are the breathing instructions?
Expiration.
Okay. Why are we doing it on expiration? Again, we're bringing the diaphragm. Expiration. Well, does the diaphragm go up or down on expiration? It goes up. Okay. So we're trying to get as much abdomen in there as possible. Okay. And expiration out does compress the abdomen. Makes it a little bit more compressed. You guys remember your KBs? Did you do your KBs on expiration? Okay. PA. Places, if you do a PA, again, it is more better for the ovaries. So less exposure to the ovaries, and it also helps straighten out the curvature of the back. Okay. It helps out. Have some of you guys done a PA lumbar spine? I know, right? Okay. It doesn't make any sense because you're having your patient move in all different directions. Radiographically, this would be the best position, but practically it's not. So you want to get at least T12 all the way down. Okay. Also to include the SI joints. Okay. So when you open up your field to an 11 by 14 or again 7 by 17, you guys should make sure you include those SI joints. Okay. Exposure done on expiration. Obliques. 45-degree obliquity. Now, this for sure you are going to be taking this shot on a field of 11 by 14. It's going to be an 11 by 14 field size. So there's no option here. Roll them up on their side, 45 degrees. How are they going to hold that position? What can we use to make sure they hold that position? Sponges, right? So use sponges to help them hold that position. Also, before you take the shot, stand at the either end of the table and make sure that their back is aligned with the length of the table. Because once you roll them up on their side like that, they kind of get cockeyed, and so they're kind of off to the side a little bit. So make sure their back is straight up and down on the table. Okay. Center A is going to be 1 inch above the iliac crest and 2 inches medial, to the upside, as is. So the as is a body part, a body landmark that you will be palpating for. You need to be careful how you do that because it's near a sensitive area. Okay? So when you are positioning your patient, you let them know you are going to be feeling for their hip bone or whatever bone you want to call it. Okay? You let them know you're going to be touching them when you do that. Okay? Also done on exploration. So you can either do the posterior oblique, which looks at the side down, or an anterior oblique, which looks at the zygapophyseal joints side up. Okay. What they're showing you over there is on the RAO, that's an LAO actually, an anterior oblique. They're going about 2 inches towards the upside of the spine. Okay, so they feel for the spine and you go about 2 inches on the upside from there. There are some options that you can do. 45 is the average. However, if the area of injury is on the upper lumbar spine, there's going to be a greater rotation of approximately 50 degrees to evaluate L1, L2. And if we're looking at the lower lumbar, 30 degrees obliquity. Now, why do we have these variances? Why do we have 50 and 30 here? Why not just 45? So 45 is right in the middle. But why do we have these variances?
Change it gets
Is the
thicker.
back perfectly straight? It's curved. Yeah. Because of the curvature of the back, okay, 50 for the upper, 30%, 30 degrees for the lower. So, evaluation criteria, L1 to S1 is demonstrated. You should see Scotty dogs. The Scotty dogs, or the eye within the Scotty dog, is going to tell you whether or not we are properly positioned. Because the pedicle or the eye should be right in the center of the vertebral body. And I have a little note there over there. If the eye is anterior to the body, because here's the anterior side, if the eye was over here, it's right there, it should be right there in the middle. If it's over here, that means that you are under-rotated. If the eye ended up somewhere back here towards the spinal process or the back of the body, then you are over-rotated. I gave you guys another example here on this next page, okay? So you want to be right in the middle of that body. Any questions? Not mine. Okay, lateral lumbar. So patient, it's a true lateral position. Oh, by the way, what did we say here? We're going to take this x-ray what? On expiration as well? Expiration? Yes, expiration. 40-inch SID. Okay, lateral. Patient in a true lateral position, bolster them up so the back is straight and the line between both iliacs is perpendicular with the image receptor without any type of hip tilt. If there is a hip tilt, you're going to use a 5 to 8 caudal angle to open up that joint space. Okay, so again, your central ray depends on the size of your field light. So 14 by 17. Are you guys doing 14 by 17s for laterals, or are you still using 11 by 14? Still 11 by 14, or back there, it depends, right? Okay. Be familiar with the 2 centerings for the different image fields. So central ray is mid-coronal plane. Iliac crest, mid-coronal plane, or a ½ inch above the crest and the mid-coronal plane. Also done on expiration. So the back is nice and straight, the disc should be open. If there is a tilt to the hip, the disc spaces are going to get closed. So make sure you bolster your patient up so that the interiliac line is perpendicular with the image receptor. And if not, then again, just match the line with your central ray. So T12 all the way down to the distal sacrum should be demonstrated. Intervertebral disc should be open. In a lateral, there is a lot of scatter radiation, so again, if you do have one of those lead strips, use it. If not, collimation is very important to make sure that you maintain that high contrast, minimizing scatter radiation. It's a good demonstration for the disc spaces as well as the intervertebral foramina. Now, I'm not sure, also hold an expiration. What does your book say? Does it say expiration or just hold your breath? Does anybody know? You guys even have a book?
On the shelf somewhere.
You guys carrying your books around. I told you guys back in the day, we had 5 of those. We had 5 volumes that we had to carry all the time.
Did you ever use them?
I carried, I think, 2 at a time. And then, you know, back then, we don't have the technology that you guys have now, where you can access all that information. So we literally had to carry our books with us even to our facility.
So were your professors?
Suspend respiration in the book, right?
Expiration.
On expiration,
End of
Suspend
expiration.
end of
Expose at end of expiration.
expiration,
Yeah.
okay. You guys do have your books. Okay, L5S1. This is called the lateral L5S1, but I think some of your texts refer to it as your spot film. Okay, it's called the spot film. Do you know why it's called the spot film?
Because it's small as a spot.
Okay. Again, going back in the day, the fluoroscopic units, when we wanted to take an X-ray using the fluoroscopic unit, there was a slot in there to put your cassette. It was a 9x9. That 9x9 was called a spot film. Okay? So when we shot this L5S1, we used that 9x9 cassette. That's why it's called a spot. So it's a reference to the dimensions of the cassette size that we used. Okay? All right. Again, true lateral. Back is straight. Interiliac spine line is perpendicular with the image receptor. Your central ray is going to be 1.5 inches inferior to the crest and 2 inches posterior to the as is. Are your texts showing you your little landmarks with your fingers? And there's different ways to do it. I mean, I used to do this. Some of you guys are
Up the crest and then.
doing this.
Yes.
Okay. Okay. It works.
It does.
So follow whatever your text is showing you, the short way of doing it. But again, for test purposes,
I can draw.
okay, it's going to be 1/2 inch